Good morning, everyone. Welcome to this morning's presentation, Strategies, Ethical Considerations, and DEI Implications Working with the LGBTQIA+ populations in Palliative Care and Hospice. Before we begin, a few reminders. To be awarded 1.5 nursing contact hours or 1.5 social work CEUs for this activity, you must attend the activity in its entirety today, August 16th, and complete an evaluation that will be available to you shortly after the program has ended in Talent LMS. No contact hours or social work CEUs will be awarded for partial attendance or failure to complete the evaluation by August 21st. The presenters, planners, and support staff in a position to control the content of this nursing continuing professional development activity have disclosed no relevant financial relationships within the past 24 months with any ineligible companies pertaining to the development or presentation of this activity. We define ineligible companies as those whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. This activity is not commercially supported or jointly provided. Choices Healthcare is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Our presenter today is Dr. Kathleen Walsh. Dr. Walsh is an associate professor at Millersville University, where she has taught since 2007. Previously, she was a visiting lecturer at the University of Maryland, Baltimore, and the University of Maryland, Baltimore School of Social Work. Kat is a proud social worker with a passion for positive change, community building, and uplifting others. She teaches a variety of undergraduate and graduate courses and has vast social work practice experience, including work in public child welfare as a community organizer and as director of several community-based programs in urban areas. Kat served as an executive director of a nonprofit emergency and homeless services agency, and she was the clinical director of the Pro Bono Counseling Project in Baltimore. Her research includes salary and social work, workforce equity issues, social work professionalism, ethics, and supervision. During the past several years, Kat has been an active volunteer with the American Red Cross and has served on a disaster action team as an intake worker and disaster mental health responder, among other roles. And I'd like to add that she has completed her sabbatical engaging in disaster response. Now, during this presentation, please enter your comments and questions in the chat box. This program will include breakout groups, and you will be expected to turn on your camera and microphone and participate in small groups. And now I would like to turn the program over to Dr. Walsh. Dr. Walsh, welcome back to Hospice.
Thank you so much for having me. When I really feel awkward when that bio gets read, I just really am happy to be able to wake up in the morning some days, especially when it comes to doing 8:30 sessions. So I want to just say thank you, everyone, for being here. And I'm going to do my best to monitor the chat, to monitor the way that things get, the way that you view things. But if something doesn't show up right, or if something's not looking right, you can't hear me, please come off mute or make a note in the chat so we can address those challenges. I'm a little out of practice lately, so I appreciate your bearing with me. Today, I just want to highlight a few things. I have given, and I will be giving out, if you haven't already received them, some detailed slides that have some background context. I'm not going to read you the slides today. I don't want folks to panic when they see how many things we're going to talk about in an hour. I prefer that we have more dialogue and discussion, and I want folks to feel comfortable jumping in if you have questions or there's things that you want to make sure that we talk about. I do like to highlight supplemental tools and resources, because the main reason that I like to do these kinds of sessions is to spark some interest and to share resources so that you can continue your learning. And that today we're kind of introducing some things, but it's certainly not the end all be all ending of when, you know, we become particularly competent in a particular area. We learn all the things that there is to know. So I do like to also point out sharing of additional information. Today, the program description, and you have also a handout that has the description as well as the outline. What I want to highlight today is that in this particular session, maybe unique from other times that we've been together, we're going to pay special attention to considerations with respect to diversity, equity, and inclusion as that relates to our ethical obligations and service obligations. And today we're paying special attention to LGBTQI plus populations, including patients and caregivers, as well as family members. What my goal is to foster a deeper understanding of some of those external macro forces that individuals and families have faced that exacerbate some of those stressors and other factors that lead to our service and resource delivery needs. So those are the kinds of things that I want us to focus on today. These are our learning outcomes that are also outlined in the outline and the session references that I will be sharing. And just because you need other slides, this is our specific agenda. I'm going to start with some terminology and clarification, and then do a quick overview of some of the revisions that were made to the NASW. So I'm looking at it from a social work lens perspective in our recent Code of Ethics update. And then what I'm going to try to do is scaffold some of those themes, particularly the need to seek cultural competency versus awareness, to delve a little bit more into what that means and how that influences ethical practice and service delivery. And so that's really where I'm going to spend the bulk of our time today. I want to just share some of those resource tools as we're getting started. Today, I am going to spend a lot of our content is coming from the second bullet, which is the best practices for sexual and gender minorities in hospice and palliative care settings resource guide. It's the LGBTQ resource guide. And I've also shared that link. And I have some other resources also that I'll point out throughout our session and hopefully show, hopefully we'll have time to show a couple different video clips that will also help us to foster that understanding. And these are some other resources that you might find helpful, particularly that last bullet. There are lots and lots of helpful resources there related to working with older adults, if that is the population that you're working with, and those that are LGBTQ plus. Some additional resource tools, just framing specifically diversity, equity, and inclusion, just to highlight. And these are all linked, and I can share any of those that you might also want to have access to as well. So in order for us to get started and for me to maybe just test out some of the features and get to see where folks are coming from, I want to ask folks to think about something that you do or enjoy that fills your bucket. But if that is too early for you this morning to think about something that's too complicated, and I can totally relate to that feeling, maybe if you have a photo on your phone or on your computer, something that brings you joy. So I'm just asking you to think about something that's going to hopefully put us in a place where we're open and receptive to hearing things, and maybe even hearing some things that might be a little bit more challenging to hear and to work through. And if there is something specific that you want to get out of today, make sure that we discuss if you want to make a note of that and post that in the chat that would be exceedingly helpful to me. So I'm going to pause my screen sharing for a minute, and I'm going to just wait to check in so that I can see folks' faces, and see if I can make these things work. So I'm reading some of the notes that folks are posting, and I am okay, good. I'm glad some folks are starting to think about the things that bring them joy, and I want you to share those. So in the chat, if you're having some logistical issues, I'm going to do everything I can to make sure that I address the technology, but if you continue to have challenges, I will make sure that everyone has a copy of all the slides so that you can see them along, and also those handouts. And I will do my best to synthesize content from the slides so that no one's missing out on anything. I am loving the things that bring folks joy. I appreciate those. The pets are probably my favorite. My family, especially when they're not angry with me. My favorite moment is, I think, when I come home for those first 2 minutes after I've been gone on a Red Cross deployment for 2 weeks. My cats and my children are happy to see me in those first 2 minutes, and then they're kind of just done with me. So I live for those 2 minutes where they care. If folks have anything specific, oh, I love it. Thank you. Keep posting those good vibes in the chat. And if there is anything specific that you want to make sure that is on my radar that I haven't already mentioned that we would address today, you can also feel free to post that in the chat. I'm going to make time at the end to make sure that we are able to address questions. I will adjust our process accordingly. That's why I like to over prepare and over deliver lots of notes, but we don't have to overshare too much, hopefully. Are there any things that folks want to make sure that we address, or things that you want to make sure that are on my radar before we dig more into that content? I want to start on a happy place. I appreciate folks' willingness to share some of those uplifting feelings of joy, things that make us happy, things that get us to a better place, and kind of try to hold on to some of those elements as we are talking about some of the challenges that folks face and some of the service delivery issues that we want to be mindful of in order to deliver the most optimal services to the clients that we're working with. I'm going to go back and I'm going to share a couple highlights from my screen, and then I want to show a little video clip for you. So hopefully I'm able to navigate these as well as I hope to. So what I want to do just to get started is highlight a few things just for context in terms of operationalizing some terminology so that we are speaking the same language. I think a lot of times we are on the same page when we're in our disciplines, but sometimes outside of our disciplines or outside of our scope, we may be using different terminology. So just want to operationalize as some of the foundation for what we're going to be talking about. Whenever I talk about ethics or do an ethics type of workshop, I like to highlight the differences between values and ethics. And it is particularly helpful, I think, to me to think about that in the way that our social work code of ethics is organized, is that our values are our core belief systems that guide the work that we do, and then they translate into our behaviors, and those behaviors are outlined typically in codes of ethics about what is specifically right. And that is a lot of times operationalized in those codes of conduct, so standards telling us this is the way that we execute those beliefs, those values, so that we are doing adequate service to others in a optimal way that is right, and also in many cases, hopefully legal and lawful and procedural. So the NASW Code of Ethics, and I'm just going to highlight a couple things just as context for the content that we're going to be talking about. Our purpose is to, again, identify those core values, that belief system that then in turn shape how we are behaving, and that summarized through our principles that reflect those values, and then in the standards for which we are obligated to practice. And many organizations, hospice organizations, palliative care organizations, lots of different organizations also adopt values and ethical standards that guide their practice. And when I do larger sessions and we have day-long times to talk about things, I have folks identify, what are those core values that shape your work as a person? And then how does that translate into our professional identities and our other types of activities that we do in our life and in our professional and our personal lives? I think it helps to just, again, revisit those core values for social work. That probably aligns with many of the other things that also align with your personal lives. Today, I think the focus is really in alignment with these first two, our capacity to serve and knowledge of the social justice and external and environmental social factors that influence a person's capacity to live a fulfilled life and with equity and inclusion. And then that transcends into some of these other areas of dignity and worth, importance of relationships, integrity and competence. And so I like to highlight that as just a foundation for our conversations. These are the folks that we have. I was joking, talking about social work. We have ethical obligations and standards to just about every single identity that you can possibly imagine. Our clients, our colleagues in various settings as professionals, to the profession as a whole, and also to society. So we're taking into account all of those different layers and levels in which we interact, and that also shape our capacity to interact and serve others. Some things to highlight in terms of the revisions to the Code of Ethics that are relevant to our conversations today, the NASW Code of Ethics, that I think it's relevant not just to social workers, but to many of us in human service professions, especially after working in the pandemic and surviving a lot of those community-based experiences, traumas that we have over the last several years. I think it's important to highlight some of these revisions, and there were two primary revisions in the Code of Ethics in 2021 to the NASW Code, and that was adding a section on self-care being paramount for the ethical practice of social work. And while the focus today is not on self-care in particular, but what I do like to highlight is that the self-care edition is an aspirational statement that is intended to also make sure that self-care is not an individual or a micro focus, but more of a macro acknowledgement that organizations, agencies, and other institutions need to promote and encourage policies and practice that support human service workers' self-care. Because for us to do the difficult work that we do, we need to feel valued and supported, and that starts from our societal level. And so that's why that piece is in there. And I think that's important for me to highlight, that it's not something to be a negative, like, oh, you're not engaging in self-care, but that we need to cultivate the space as organizations and as a society for self-care to be valued and important, especially in doing the challenging work that you all do. The main focus of our session today, as it relates to the Code of Ethics, is the reinstatement of the language of competency as it relates to cultural competency, diversity, equity, and inclusion. And so these next couple slides, I'm just going to use as a backdrop to highlight some of the language and the importance and how it aligns specifically with the social work code of ethics, but also with the work that you're doing as employees in hospice and palliative care settings. Take one moment to just look through the yellow on this slide highlights the revisions, but I think this provides a really important context for the work that we're doing now and the things that we're talking about today. Some things that I want to reinforce, as if my highlighting isn't enough, is that we take action. It's an active statement against oppression, racism, discrimination, and inequities, and acknowledge our own personal privilege. And I think that's a really important assertion, and I think it's an important to highlight in the context of our conversations today. My main goal is to help continue to foster awareness and understanding about the differences that folks might face based on their different experiences in life and how that is shaping end of life types of interactions and services and resource needs. Just to take a moment to pause to take a look at some of, again, the terminology. What do we mean when we are talking about cultural competency and cultural humility? Additional resources, and again, these are cited. I don't expect everyone to memorize, but I like for us to have a shared understanding of terminology. I have included these in the handouts as well as the references. What I think is really important in our focus today is the language around inclusion and our capacity to be tuned into our work philosophies, our social and organizational policies and practices, so that we can think about and be mindful of how those may either inadvertently or adversely impact the ways in which we serve folks. And I want to, I'll give some specific examples as we get into the content a little bit more, but I want to highlight that and ask folks to pay a little bit closer attention. So some key themes in hospice and palliative care that I think are important to highlight as a context for our conversation today are listed on the slide here. I want to encourage folks to take a moment to just review these themes and pay special attention to the words that I've put in bold here. So some important considerations related to our topic, our specific topic today. Patients that identify as being lesbian, gay, bisexual, transgender, queer, or other gender and sexual minorities may require additional care, concern, and compassion especially when they're experiencing serious illness and end of life care. It's important to consider that healthcare disparities, including the psychological and physical needs that may not have been fully met, um, can also shape additional subsequent needs and exacerbate health conditions as well as other factors that influence folks' lives. I'm going to pause this for one moment so that I can share a video clip as some context. So I'm hoping you're seeing my video and I'm hoping you're hearing it, but stop me if you are not. This is just a little case example to highlight some of the factors that we're going to be talking about.
As the American public ages, so do lesbian, gay, bisexual, and transgender people. LGBT older adults face the same challenges as other older adults, including financial worries and health concerns. But LGBT older adults face additional challenges. Let's compare two women, Tina and Jackie, who were both born in 1947. In 1967 at college, Tina meets Frank, and Jackie meets Francis. On a date with Francis after work, Jackie is seen by a coworker who tells their boss. Jackie is legally fired and takes a lesser paying job at a factory. In 1973, Tina marries Frank, but Jackie is unable to marry Francis. In the 80s, Tina and Frank have children, but Jackie and Francis are barred from adopting. After decades of hard work, in 2010, Frank and Francis retire. Tina takes Social Security spousal benefits. But because the federal government didn't recognize same-sex marriages then, Jackie is denied those benefits. In 2015, right before the freedom to marry becomes available nationwide, Frank and Francis die. Tina pays for her in-home care with her Social Security survivor benefits and funds from Frank's pension. Jackie is denied Social Security survivor benefits, and because she was not a legal spouse, is also denied Francis's pension. Their apartment was rented in Francis's name, and her state lacks non-discrimination protections in housing, so Jackie is evicted when she tries to change the lease into her name. Lacking an income and a place to live, Jackie moves into a nursing home and relies on Medicaid to pay for it. She fears discrimination if she shares stories about her past, so she doesn't talk about her life with Francis. Tina can afford in-home nursing care and has the support of her children. After a lifetime of discrimination, LGBT older adults face economic insecurity, poorer health, and reduced support networks. Find out more about the unique disparities facing LGBT older adults and how to remedy them, as well as the strength and resilience of LGBT adults at lgbtmap.org/older adults.
Just gonna pause there just to check in with folks. I only have one screen, so I'm trying to be tuned in to the different chats and so forth. But I wanted to pause a minute and see if folks had questions or insights or thoughts about the video or about some of our topics that we've just introduced thus far. Seeing none, I'm going to go back to the presentation and I want to highlight a few additional things. The resource guide, so just as an aside, the content in these 5-6 slides here, as well as the foundation for some of the solutions that we're going to be talking about today, is out of the LGBTQ plus resource guide published by the National Hospice and Palliative Care Organization. I've shared that link with folks, but that is where I'm getting a lot of the references and the recommendations for our context. A few things that I want to highlight, as well as especially, I think this is important, is the glossary of terms that I've also highlighted from the Human Rights Campaign. I think it's really important to point out that there are nuances in the ways that folks, especially generationally, may identify, especially when identifying sexual and gender minorities. And so the NHPCO uses the terminology LGBTQ plus to be inclusive of those who, for personal or political reasons, do not feel represented by lesbian, gay, bisexual, or transgender identifiers. It is important, again, that respectful and competent practice requires an understanding, or at least a willingness to seek understanding about language and about our terminology, and ways that we can learn more about that using the Human Rights Campaign glossary of terms. It's also highlighted in the resource guide that I distributed. It's also very important to meet clients where they are, and honoring individual identities as folks present and use the pronouns as they identify. It's also really important to consider and highlight some of the healthcare disparities that are faced by LGBTQ plus populations, as well as the intersectionalities of other identities, because they also represent additional diverse communities, geographies, parts of the regions, the country. Our nuances are significant and also influence healthcare outcomes and healthcare disparities. Folks frequently experience the socioeconomic detriments of health at higher rates than heterosexual folks. And unlike other types of minorities or underrepresented communities, they may be invisible or seek to be further invisible in their minority status. And in many cases, this can increase vulnerabilities to mistreatment, to marginalization, as well as to neglect. Some data, and I think it's important just for context. I don't want to read off a whole lot of data. I am going to highlight some statistics that I think are important to the topic at hand, is that when it comes to having additional support of adult children, in the 20 states, that includes DC, that have the highest percent of LGBT citizens, still 35% or less of those LGBT adults are raising children. And consequently, they may be less likely than their peers to have built-in supports of adult children. It's likely that they may also face serious illness, and at the end of life may not have the same types of extended family support that non-LGBT patients have. So in terms of some support considerations, I think it is important. I said I wasn't going to give you a whole lot of data, but I do think that some of this is helpful in terms of fostering our understanding and in empathy. And so I want to just highlight a few things, particularly those that relate to access to healthcare and health insurance. So I want to take a moment and encourage you to take a look at some of the statistics that are on the slide here. And I'm not going to read them, but I want to ask you to take a moment to review those and see if you have any thoughts or feedback or want to weigh in on any of these. gonna stop sharing for a moment just because I wanted to pause to check in. Um, Thoughts about access experiences that folks have had, um, mediating or navigating or experiencing some of these kinds of disparities or access really barriers. Then I want to encourage you to consider the impact of some societal biases on physical health and well-being. And so I want to pause a second, take a look at these three characteristics. I think that, and I also want to highlight that the data in this report is a little bit dated, and I'm going to argue that we haven't done much. That probably, if we look at the numbers again today, that we wouldn't see vast dramatic differences. And it's an important consideration. Societal bias impacts our physical health and our well-being, and then it spills into so many other facets of life and of capacity to have a quality of life, including a quality in ending of life care and end of life decision making. A couple other considerations, looking at risk factors among LGBTQ youth.
Pat, I do have a chat question. And
Excellent.
you
Let me
answered
stop.
you answered it a little tiny bit, but it says, how were these percentages obtained and what percentage of population were surveyed?
That's great. So that's a great question. And so the full reference is at the bottom of the slide, but this information that I'm referencing is out of the National Hospice and Palliative Care Organization LGBTQ plus resource guide. And the data that they're referencing is from the, let me get the right reference. How to Close the LGBT Health Disparities Gap from the, I'm gonna post this very direct link to get it for you because I actually pulled it up because I wanted this question to be asked. So I'm gonna post this specific reference in the chat, and they're also linked through this. You can get to, or I can help navigate if you want me to, additional references for follow-up. So I'm going to post this link and hopefully it will work. Because I do think it's important that not only to talk about the disparities, but talk about how do we close that? How do we address those gaps? And what are things that are working? If it's better in some areas, why is it better in some areas than other areas? And so that's what some of these resources will help us so that we can pull out, well, the places that are faring better, what kind of things do they have in place? And that's kind of some of the content that we're gonna get to from both the macro and a micro level a little bit later on. Does that answer the question at least, or at least give a good reference? Well, I'd be happy to talk more. I can talk data, not all day, but like a little bit more. So I'd be happy to talk further about those questions. So hopefully you're seeing my right screen out. So a component of that I think is important, and I want to highlight, and it really, this was for me the maybe one of the biggest aha factors when I learned about minority stress and what that means and how that has a cumulative effect on one's entire identity, well-being, health conditions. And minority stress is chronic and based on factors that are outside of the control of individuals, including social structures and prejudice. Sexual and/or gender minorities are not inherently less likely to have access to health care or be healthy, but it is those factors like discrimination that lead to some of those disparities. It's also important to acknowledge that when we're considering that minority stress, that LGBTQ plus communities also contain members of other diverse socioeconomic, racial, ethnic, and religious groups. And so we have to be careful not overgeneralizing about the role, what types of intersectionality, what types of minority stress may be coming into play. But it is certainly important to acknowledge those factors and the role that they might be playing in a specific situation. And to that end, I think it would be helpful. This person describes it a lot better and more concise than I have. So I'm going to share my screen again and show another video clip that helps to characterize what we're talking about when we talk about gender minority stress and what that framework, how that influences folks.
Now, the gender minority stress framework, you have that diagram in front of you. So this diagram encourages you to look downstream, right? Arrows are one directional. I want you to flip your perspective and I want you to look upstream at that very first box, enacted stigma and related stressors. And when you do that, I want you to think about Michael. Michael is a 25-year-old who identifies as a transgender male. And Michael, about 6 months ago, finally got the promotion that was much deserved and much desired. And with that promotion came a new office in a new building with new coworkers. And almost immediately after he assumed that new position, he became the target of daily harassment, bullying, and discrimination based solely on what bathroom he should use. So if that has never been your lived experience, I just want you to close your eyes, take a few moments, and think about the impact of that on your own mental health and physical health. And then I also want you to think about what lengths would you go to deal with that. So I want you to hold that. I want to keep Michael in your thoughts. We're going to talk more about the minority stress framework. So the key point is that stressors specific to gender diverse people lead to poor mental and physical health outcomes. And the more minority identities that someone has, the more likely they are to be the victim of discriminatory experiences and anti-trans bias. We're going to talk about those downstream effects. These are our health disparities, the health inequities that we're going to cover. So here's the lengths Michael went to. Michael spent hours mapping out all of the public bathrooms that were close enough to his building that he could get to and back to his office before anyone noticed he was gone. And then when Michael realized that wasn't sustainable, he decided that his only option was to restrict his fluids so severely that he needed medical intervention for severe dehydration and medical intervention for severe constipation. He had been in remission for over 8 months. All of those symptoms returned with a vengeance. So when Michael came to see me for that follow-up visit, Michael did not need me to be an expert prescriber. I thought he did, right? That's what I wanted to do. I mean, that's what I do. He didn't need that. What Michael needed was for me to be an affirming mental health care provider. and to ask him about his lived experience. And when I finally did that, then we were able to bring in a team of people and work with Michael. You can't medicate away discrimination. Okay, you can't medicate away someone being targeted because they want to go to the bathroom.
Pause a second and just check in. Oh, so sorry. I just kept it going. I wanted to just talk to folks about thoughts. Have you had experiences? Have you seen this? How does some of that insight relate to the work that you're doing and maybe some of the challenges that you face? And if you don't necessarily have thoughts that you want to share in this form, I encourage you to make some notes. We're going to have a breakout session towards the end, and I want you to think about, what can we glean from some of the knowledge. So we're rattling off a lot of information. It's not intended to foster a deeper understanding to then shape our capacity to be with folks and be with folks that have experienced additional factors and influences that are making end of life care more complex. So just to highlight the important acknowledgement that folks may experience additional disparities in healthcare access, and that can be exacerbated for people of color who may also have faced discrimination and microaggressions. There's increased threats of violence, and it's important for us to be mindful of those factors, and that it may be in the forefront of someone's experience, but it may be something that is just deeply internal and may not even be something that is currently in one's consciousness, but has shaped their experiences and their identity, and maybe their trepidation in working with folks. One of the biggest concerns reported, and I'm going to show one more video clip because I think it helps to highlight some of these case examples about what folks fear in terms of accessing care and dealing with some of the most complicated health decisions and health experiences for family members as well as those directly impacted. So I want to show one more video clip. If I can make it come up right away, that would be amazing. It didn't work. And we just got to have a commercial break. One day I'll get good at the transitions, but for now, that is just not my forte. Thank you for being patient with me.
With these, because if something happens to me and
Anita Martinez is an unofficial archivist of what she calls the rainbow community, but history is weighing heavy on her, and she's starting to think about a day when she might not live here anymore.
You have to face facts. Yeah, like nobody gets out of here alive.
She made a call to a long-term care home years ago, asking if they were LGBTQ friendly.
He said, "Oh no, we don't have any of those." I mean, he was really, "Oh no, we don't have any of those here." And I thought, really?
She hopes soon there may be a better answer.
Today we're coming together to announce and to celebrate the unveiling of Canada's first ever national housing strategy.
2 years ago, the Liberal government put forward a strategy for the next decade, promising to spend billions of dollars tackling housing for people most in need. The government's 41-page strategy said LGBTQ seniors require housing help, but it also said there are significant gaps in what we know about their needs. In other words, the money may be there, but no one knows how to spend it. That's where Jacqueline Gehagen's work comes in. This fall, she will travel to 5 cities across the country doing research that will be shown to decision makers at all levels of government.
So I think we're actually at the best time we have been in the history of this conversation about how to address the housing needs of LGBTQ folks, because there's money.
She's found some solutions that could be tested in long-term care homes within the next 5 years.
So some type of standard national training might be a concrete policy objective, but in terms of things such as ensuring that there are LGBTQ safe spaces in existing facilities is also important.
This long-term care home is already benefiting from Gehagen's research. Over the years, their understanding of how to treat people has grown deeper.
Like Mr. and Mrs., if you put that on a form, somebody could be uncomfortable if that's not how they identify themselves as Mr. and Mrs. So there should either be another or not, or don't ask it at all.
Diversity training is given to all staff, and sometimes even to residents who must share space with a roommate.
So it may mean moving people. It may mean educating people.
Ryan says long-term care can be a person's final journey, a journey no one should have to make while pretending to be someone else. Shayna Lux, CBC News, Halifax.
Just want to make sure it doesn't start playing the next video here. I'm gonna switch back over. I'm sorry, my transitions are not as much as I would like for them to be, but I think it's, again, that helps to illustrate. And I hate to be the one that is talking about all the challenges, but I think it's really important before we get into solutions that we talk about the challenges that folks face and the acknowledgement that there are some solutions. And I know that example right there was from Canada, but it was the best one and the shortest to capture what folks experience, and that there are solutions, so that a lot of times it is our consciousness raising that turns into the ability to do more tangible things to foster comfort. The example on the paperwork I've experienced myself doing intake, where we may not even realize until we're completing different forms that our forms have an inherent bias, that are gender biases and status and spouse biases. And it's not until we're starting to read them that you realize, oh, wow, there's probably a more inclusive way that we could say that. And so I think an acknowledgement of looking at the ways in which we interact, the ways in which our clients interact, the ways in which we as a society interact, and what ways we can have conscious efforts to be less stigmatizing. And some of the solutions I've listed, or these are out of the recommendations from the manual that I referenced earlier, but some things that are important in terms of identifying the challenges will lead to then what solutions are available to us. And so I've got a couple of these slides I just want to highlight, and then I want to do a little quick breakout group. I think it's very important, especially as we think about the support needs of the populations that we serve, that there might be different types of support networks available to folks, and that using language that's more inclusive, chosen family versus biological family, being aware of the fact that that might exist, I think is an important consideration, again, in terms of fostering inclusive ethical practice. I think that this bullet point number 5 is incredibly important to think about and to be mindful of in terms of noticing and fostering solutions around some of those challenges. So our ethical responsibilities, and I'm going to quickly go through a couple of these slides because I want to get to the point where we can do some breakouts. But it's important to acknowledge that those of us that have certain requirements, professional credentials, we're held to different kinds of standards, or we're held to higher standards, or we're held to professional standards, and there might be consequences for unethical conduct. The types of ethical issues that we're talking about today are not necessarily the common types of ethical dilemmas that we are accustomed to dealing with in some of these trainings. Not necessarily about choosing between two harms and two goods, but a lot of times it's about more about that awareness of the organizational and societal macro ethics that might be influencing our behaviors related to service delivery and resource needs. So it's more about the ways in which our organizational and societal structures affect our capacity to serve those clients. And that's where we get into some of those different classifications of dilemmas that I tend to focus on in some of these trainings. I'm gonna flip through a couple more slides because these are the ones that these are the same kinds of slides that we talk about usually in our other trainings that we do, because I want to bring it back around to the case examples and give you an opportunity to talk with each other and to maybe talk about some strategies that you've employed. I try to cultivate time as best as I can in our sessions so that you can talk amongst yourselves. And so what I'm going to do now is in the chat, I am going to post 3 general questions for discussions. And then I am going to create some breakout groups with about 3 to 4 folks, and I'm just going to create those manually. I'm just going to have those pop up. But these are the things I want to give you an opportunity to talk about, to choose even what you want to talk about. If you have some specific case examples where you want to elicit some feedback from your peers related to ethical dilemmas or some of the topics that we're talking about today. If you don't have any specific things that you want to talk about or any specific cases, then I want to have a general conversation about what is something from today that you can apply in your practice. If we haven't yet gotten to it, what are some questions that you might have for ways in which we can integrate this into practice? The next slides after our breakout provide some insights about solutions and strategies for being able to foster more inclusive environments for LGBTQ+ populations. And then lastly, are there ways that we can institutionalize some of our efforts so that we can maximize outcomes and increase service delivery organizationally and societally? So I'm going to try to do quick math. I'm going to create some breakout rooms now, and I've posted that question. I'm going to give you about 10 minutes in your groups. I'll give you a 2-minute warning, and I'm just going to create those now and try to designate someone that is willing to take a couple notes and maybe report back to folks as a group, and then we'll conclude when we come back together. So you should all now be invited to join a room. I've got, if you're able to do that, that is absolutely wonderful.
Just want to remind everyone that you must join the group in order to get your certificate today. This is a 10-minute part of your presentation. Pat, can you turn your microphone on and your
Yes.
video? No one can see the questions on the slide. Is it possible that you could say those questions one more time for the group?
Can I? Yeah, I think I can just broadcast them.
Okay.
I thought that posted them. Yeah, sorry. Here is them. Yeah, I'm going to broadcast it to everyone. Hopefully that worked.
I don't see it.
I think you have to be in the, you should see it on the chat currently.
Oh, okay.
And so me broadcasting it sent the message to everyone. I will also check again.
Okay. Since I'm a co-host, I'm not part of a group.
Right. Sorry about that.
That's okay.
Do you want me to extend the time a little bit since I had trouble getting that broadcast information out?
Up to you.
I include lots of detail on the slides, so I can give them a few extra minutes and just make sure that
Okay.
we have enough time to process a little bit. I think that Zoom is very convenient, but I really appreciate seeing your faces because I didn't realize all these wonderful people that I like so much are sitting here and not just little black boxes. It's good to see you, Carrie and Lisa. I'm looking at your smiling faces and I feel a lot better, and Ruth too. I feel a lot better when it's just not like I'm just talking into the abyss of the world. So I think everyone is on their way back to joining us, and I apologize that I didn't do a better job making sure that you had the prompts when you had the breakout rooms. I think that's a quirk in Zoom that we need to fix, but I want to make sure that we have a little bit of time. I try very hard, even if we have short amounts of time for these sessions, to give you opportunity to talk with each other, because I think a lot of things at least are initiated at that level. And so I want that to be able to happen. And we're almost all back. So I think we have everyone back now, and I apologize for some of those technical things. Trying to cram in too many things in a short amount of time can sometimes be a challenge, but I do think that part is important to allow you to talk with each other. And I do want to just highlight that detailed handouts are being provided if you haven't already gotten them. All the detailed slides from today, including ones I didn't even show, some supplemental slides. I have some summary slides I'm going to highlight towards our very last couple minutes. And also the resource tools that I've referenced, they're all in there, and they're also hyperlinked. So you'll get an email with all that information as well. And if there are things that we didn't quite get to discuss or other resource needs that you have, I want to encourage folks to please reach out to me. I know we're trying to cram a lot of really important stuff in a short amount of time, and I don't want to do that a disservice. I wanted to focus today really on sharing some information and heightening some awareness so that we can then take that information and do some things institutionally and individually with some of that information. And so to that end, I just wanted to put out there, if you have things that you want to share, so feel free to post any of the feedback that you have from your group discussion or individually for me that you don't mind others seeing, post that in the chat. And then I just wanted to open the floor if folks had specific things that you spoke about in your groups, things that you will apply in practice, or things institutionally or societally or otherwise that we could be doing to enhance service delivery, especially among LGBTQ+ populations. So I'm going to turn my mic off and see what happens now. And I just realized that even though I typed the prompt in the chat, I never actually hit send. So that's maybe why you didn't see it. And I hope that makes you all feel a little bit better about yourselves today. That explains why it wasn't there. I'm also pasting a link directly to the resource guide.
I just want to share that the resources that Kat is mentioning right now, along with her PowerPoint, will be provided in Talent LMS. So you don't need to do any special lookup. They will be available to you in Talent. And
Yay.
I was just wondering if anyone can share too in regard to this presentation, which is awesome, and the videos were so helpful, Kat. Just perhaps a story where they're an experience working with a patient that encountered some of these issues, and anything that we've done to help address them or support them.
I'm imagining the silence is not because we can't think of examples. It's about finding the right and perfect example. That's my.
I hope Sarah doesn't mind me sharing. Can you hear me?
Yes.
Okay. She had mentioned that one of her patients at the inpatient center was dealing with grief because of their child who was LGBTQ, kind of a relationship barrier, and that this patient was going to his end of life or her end of life with that barrier in place, and concern for their daughter or son. And that just is heartbreaking to me that it happens. It does happen, but I think, providing the opportunity for them to share and process, that's something that we have the privilege of doing.
Thank you so much for giving that example, because that's the other side of it that we really hadn't gotten to today, is that folks facing end of life may be dealing with some of that relationships in their own, like in their family structure, in their lives. And that's the kind of the other side, an additional factor that I hadn't quite gotten to yet. And I think that's also a really important, consideration in our being able to bear witness and foster that dignity and help them maybe in dealing with some of that processing. Are there other? Yeah, go ahead.
It really is a different kind of support.
Elaborate on that.
Yeah. Well, it's just rather profound, where we walk beside patients and families and support them, and being the compassionate individuals and professionals that we are, it's just hard to support someone who may not understand or want to be compassionate toward their own family. It's challenging, and I'm I don't work with patients and families, so there may be some other comments from social workers that they might want to share.
I think that consciousness, like, I think a lot of like, go ahead.
I was just saying it is really difficult. Sorry.
No, I think, I mean, I feel badly, because I almost feel like in trying to talk about what we're talking about in a short amount of time, it takes that hour and a half for us to just kind of warm up to one. It took me that long to almost wake up. So I support others who might be just waking up now as well. But just to get through some of that, you got to really foster that consciousness raising, but that's just the start. And now we're dealing with the emotionality and the differences, and it's so multifaceted, and there's so many layers that we can scaffold in and think about, and what about this part, and what about this part, and how are we in those positions where we're navigating, and there's so many nuances, because we're also dealing with multi-levels of generational factors that influence. What I like to hope happened today, or what I hope folks will take away, is to be thinking about this in a different way, and in ways that we can support each other, and the things that we can do organizationally. Even, it might just be a little thing like, oh, I didn't even realize I use that language. Like I realize sometimes I use language husband wife and not like spouse or partner, or certain language that we might not even realize that we're using. And so just an increased sensitivity can really go very far when it comes to joining and connecting with folks. And so my hope is that even though we're here for a short amount of time, that it will spark your interest, and that some of those resources that I've shared, or some of those conversations that you'll be starting, will continue, and then maybe lead to other support avenues, or other ideas for ways in which you can support your families and support your clients. I'm going to flip back over to my PowerPoint really quickly, just to highlight some of the other things that you're going to see in conclusion, and just draw your attention to some of those as we're wrapping up. I'm going to end this show portion. What I want, oops, sorry, I'm going to go back to show this window. So you should see my handouts now, right? You see the PowerPoint slide thingy, but not in view. Okay, so I wanted to point out, I like to over prepare. So the last few slides that you're going to see in your handout are some recommendations and strategies for how we can make things a little bit better, especially in dealing with specific considerations among LGBTQ+ populations. Knowing and being educated about our client needs and rights is critical. The handout and the presentation has some recommendations and some additional resource areas where you can look at about what some of those strategies might be based on the specific client situations that you're faced with. I also think it's really important to highlight the important spiritual concerns and spiritual care considerations. And so there are also some specific recommendations in the toolkit, as well as in the slideshow, about some strategies to think about, and some ways in which we can foster more inclusive feelings and affirming interactions and supports for families and individuals. I've also included in the handouts some strategies for, again, when you're faced with resolving dilemmas, what are some of the most important things that we can do? Is involving others in those decisions, weighing the pros and cons of those challenges that we're being faced with, and then thinking about how it is that we bring about those desired outcomes into fruition. I've also included some supplemental slides about strategies for dealing with your own experiences related to implicit bias and prejudice, and then some additional references and recommendations for reading, and the videos that I showed, as well as some longer videos, are also included in your handouts. I also, in the outline, have some links to some supplemental, there's some really great toolkits available, and I couldn't possibly cover them all, but based on the situations that you might be faced with, I think some of those resources can be really practical and useful for you. So that was me trying to cram all the rest in the amount of time that we had together. So questions?
Or comments?
Yeah.
I was going to say, just a comment. Thank you so much. I think it was really great, the little breakout room, because, York and Lancaster are so separated. We don't always get to talk, besides emails, maybe, to our, our peers over in Lancaster. So I appreciated that. Thank you.
Oh, yay. I try, like, at the, I'll over prepare, give you handouts later.
That's great to hear too, Ruth. I appreciate that too. There was a chat comment. Thank you for this wonderful presentation. And also, Kat, thank you. It was a very powerful presentation, insightful presentation. I loved your videos because they were short, and the stories were very powerful and shared a lot in that brief period of time. Does
It's a lot to accomplish in a short amount. So I apologize because I feel like I'm talking fast and I'm trying to cover a lot of things that I think are important, but I'm glad that you have the interest. I think the most important thing is the interest and the awareness and just wanting to know more.
There was another comment. Thanks, great content. Again, thank you. This was great. I think it just it puts people, and I think to a certain extent, certain staff, it puts you on pause. The presentation puts you on pause to really assess and think about yourself. And I think that's powerful, because even though there may not have been a lot of response to your initial questions, I think people were on pause.
Yeah.
Thinking about it. So,
there's a lot involved generationally.
Yes.
I have a 19-year-old who identifies as LGBTQ population, and I asked them last night to read through my presentation, and just with a different lens, a youthful lens, like noting that privilege. And it's very interesting to me also generationally. When you're working with folks that might be in their teens and 20s, they've had a different life experience than Gen Xers. Like my generation, I joke when we talk about the Q word, queer was something you said as an insult to someone. So I'm still having trouble with certain language. And so that leads to different kinds of conversations, even generationally, about what things folks have faced in their lifetimes. And I think it really it helps all of us to think about what different folks at different points of their lives and different generations faced from macro forces that influence, what we're dealing with now at different phases in our lives. I think it really is important. I overstayed my welcome. I can keep talking. I welcome the opportunity to have seminar discussions about subjects and so much less lecturing.
Well, I do have to wrap it up, unfortunately. And I just want to remind everyone, you will be notified shortly via Talent LMS when the evaluation is ready to complete. And again, the evaluation must be completed by August 21st. First, to receive a certificate for nursing contact hours or social work CEUs. A reminder about next week when our pharmacist, Kathy Worley, will present the topic psychedelics and drugs of abuse. So everyone, stay safe. Again, thank you, Kat, very much.
Thank
Our
you.
program has now ended.
Thanks a lot, everyone. Appreciate it.